Hi, everyone. Happy Thursday. This is Hiral Patel. I'm an interventional pain management specialist. I practice in Sugar Land, Southeast Houston, and Pearland area. I'm board certified in anesthesiology and pain management. I treat chronic pain of all different kinds. My goal is to help improve daily function of my patients and their overall quality of life. Today's topic is bulging discs, pinched nerves, and sciatica. What does it all mean? Let's start by talking a little bit about back pain. Back pain affects 80% of people at some point in their lifetime. The good thing is most episodes self-resolve and does not require involved medical care. Back pain can also have functional and emotional limitations. It is said that 1 in 5 people are limited in their daily activities due to low back pain. It can also have financial and economical implications. World Health Organization states 100 million work days are lost on average per year from low back pain and reduced productivity. At any given time, it affects about 15% of US population. It's also the 5th most common reason for all doctors visit. And this is, it follows any respiratory symptoms such as chest, like cough, cold, infections such as pneumonia, any cardiac symptoms such as chest pain, palpitations, any endocrine symptoms such as diabetes, and nervous system symptoms such as a headache. There are many different causes to low back pain. The most common cause is nonspecific in about 75% of the people, and it tends to be from muscle sprain, overuse, poor posture. The topic that we're focusing on today, which is from a back pain or leg pain from a bulged disc or a pinched nerve, it makes up about 5% of low back pain. Let's talk a little bit about anatomy of the spine. It consists of vertebrae, muscles, ligaments, discs, and nerves. In terms of the vertebrae, you can divide it into cervical, thoracic, and lumbar region. The muscles and the ligaments that are around the spine are some of the strongest muscles we have in our body because we're constantly using them to maintain a certain posture. They help support the bone and the discs of the spine by unloading some of the pressure. The discs are the shock absorbers of the spine. They help stabilize the spine and they help with flexibility such as bending forward, back with rotation. The nerves carry information from the brain and the spinal cord to the rest of the body. And some of the information that it carries include information on strength, sensation, and autonomic functions such as temperature control, anxiety, fight or flight response, sweating. So there's an image here on this slide that shows the normal alignment of our spine. That can change if you have pain or degeneration. Let's talk a little bit about the intervertebral discs. The intervertebral discs are present between each of the vertebrae in cervical, thoracic, and lumbar region. It has an inner and an outer layer. The inner layer is water-filled. It's gel-like and rubbery. It expands and contracts depending on the load it receives, and it's called nucleus pulposus. The outer layer is called annulus fibrosus, and it's very tough, and it helps provide strength and stability to the disc. As the discs undergo degeneration, especially when we age, there are certain things that happen to the disc. First, it starts losing its water content. It loses its gel-like material. Then it starts losing its height. And because of those two things, it loses its elasticity or its resiliency, its ability to really absorb the pressure that's placed on the spine. And then it loses its strength. So here's an image of the disc from the side, what it looks like on our spine, and from top to bottom. If you were to slice it open, that's what it looks like on the image there. So when the discs undergo changes, it has an increased risk of moving out of its normal space. And when it does move out of space, it can cause pain. There are 3 basic grades to a bulging disc. Grade 1 is a protrusion or a disc bulge. Here, there aren't necessarily any changes to the disc itself. It has an intact outer and an inner layer. The 2nd grade is a disc herniation. Here you can have a tear or a rupture that occurs to the outer layer of the disc. When it does herniate, at that point, it can start putting pressure on nerves and other surrounding structures. The last grade is disc sequestration or a disc rupture. Here, the inner gel-like material spills out. This material is very irritating for the spine and the surrounding structures and can cause a lot of swelling and pain. So what are some of the risk factors for a bulging disc? There are many. Age is an important risk factor. Being under 20 or above 50, because it has to do with bone mass. We don't acquire majority of our bone mass, about 90%, until age 20. And then we start losing our bone mass after age 40. Also, if you do excessive lifting, if you carry heavy items repeatedly, if you do a lot of forward bending activities, you're at a little bit higher risk. If you're overweight, you can put a lot of stress on your back, which can put you at risk for a bulging disc. Chronic smoking has been shown to be associated with bulging discs. And this is partially because the byproducts of tobacco prevent the discs from absorbing all the nutrients it needs to remain healthy. Lack of physical exercise can weaken the muscles around your spine and put you at risk for bulging discs, along with chronic medical conditions like high blood pressure. There is also a genetic component to bulging discs that certain genes have been shown to be associated with it. Similar to lack of physical exercise, if you're in the hospital for a very long time, you can weaken the muscles around the spine, and that can put you at risk for bulging disc. And that's why it's very important to keep your back conditioned with stretches and exercises on a routine basis. So when you have a pinch nerve, when you have a bulging disc, what kind of symptoms can you have? If the bulging disc is not putting pressure on any surrounding structures, you can have no symptoms or just back pain. If it starts putting pressure on surrounding structures, which includes a nerve, either in the canal centrally or on the outside in the foramen where the nerve roots come out, you can have pain in the back as well as pain that travels into the leg. This can be associated with numbness or weakness in that distribution of the nerve. So the image on top shows what a normal canal looks like from top-bottom view. And the image next to it shows where you can have stenosis, so narrowing of the central canal, and on the sides and the red area are the nerves that are being irritated from a disc that has bulged. So when you have pain from a pinched nerve that starts in the back and goes into your buttocks, maybe your thigh, groin area, lower leg, foot, it's called sciatica or radiculopathy. This pain can be associated with numbness or weakness. Nerve pain typically feels like burning, tingling, shooting, aching, pins and needle, ants crawling, electricity like shock sensation. It pretty much hurts to do anything when you have nerve pain. It also doesn't respond very well to traditional pain medications. When you have leg pain, you do want to rule out that it's not from other causes. Some of the causes include a problem with blood circulation. Usually when you have a circulation problem, pain in your leg may not be associated with back pain, and it gets worse with exercise, walking, and it gets better with rest. You can also have neuropathy, and this pain usually starts distally and works its way up. So it starts at the toes and works its way up to involve the foot, ankle, and maybe the lower leg, kind of like in the distribution of a glove. You can also have arthritis-related pain, and this can be localized to your hip area, knees, ankles, or the foot. So when you have pain in your back or in your leg, when do you want to get evaluated? When do you want to go see a doctor or go to an urgent care or an ER? So this can be anytime you have trauma. This includes a fall, an accident like a car accident, or an injury at work. You do want to get evaluated. Anytime you have a combination of fever, chills, and night sweats, and back pain, which can indicate maybe some kind of an infection in your back. Anytime you have rapid weight loss or unintentional weight loss of more than 10 pounds, this may indicate possibly cancer in the back or some kind of autoimmune or infectious cause for your pain. Anytime you have significant weakness in your legs where they feel really heavy, where you feel like you may be dragging your feet, for example, when you have significant numbness in your legs, or if you start losing control of your bowel or bladder, you want to get evaluated. Or if your pain can't be controlled at home and you would like to know why you have this much pain, and if you need medications, you can go to your doctor as well as the ER or urgent care. When you see a healthcare provider, you will be asked a series of questions. It's important to answer these questions as accurately as possible. This can give us a lot of information that's useful and can help us come up with a good treatment plan for you. Some of the questions you will be asked include, where is the pain located? Is it only in your back? Does it go down your leg? When did the pain start? Since the pain started, has it gotten better or is it getting worse? What is your pain level like at its worst and at its best? Does the pain come and go or does it stay constant? Have you had prior history of such back pain before? If so, what did you do at that time to get it better? Along with this pain, do you have any numbness, weakness? Are you losing control of your bowel or bladder? And then if you've tried anything for this pain during this episode, such as medications, therapy, etc., and also what makes the pain worse or better. We'll also ask you about your medical history, anything that you've been diagnosed with, your allergies to medications, your surgical history, the current medications you're taking, any social history. So do you smoke currently or have you smoked in the past? Do you drink alcohol? Do you do any drugs, etc.? And family history of any major medical conditions or back pain. We'll also examine you. We'll start by getting vitals, which includes your blood pressure, heart rate, oxygen level, temperature, your height and weight. We'll also see how you walk. So we'll check your gait. We'll see if you're able to bend forward, back, and to the sides. We'll feel your back and see where you hurt. And then we'll check strength in your arms and legs and compare them on both sides. And then we'll check sensation in your arms and legs and check reflexes. And then we'll do certain tests, which may give us an idea as to what's causing your pain. One of the tests we would do is called straight leg raise test, where we'll ask you to lay flat on the examination table. We'll raise one leg at a time. And at a certain point, you may start having pain in the back that shoots down your leg. If that's so, it may indicate that you may have a pinched nerve in your back. We'll also consider getting imaging of your back. Imaging is not always needed for back pain, partially because 80% of back pain gets better by 8 weeks, 90% by 12 weeks, and then 93% by 24 weeks. But if your back pain continues past 4 weeks, or if it's getting worse and you have persistent leg pain, we will consider getting maybe an x-ray of your back, CAT scan, or an MRI. MRI tends to be the best imaging test to look at your spine, especially the different types of disc herniations and nerves. So we may consider getting that. When you have back pain and or leg pain from a bulging disc, you do want to start out with conservative treatment. This includes lifestyle changes. You want to take it easy. So you want to avoid lifting heavy objects, anything more than 10, 15 pounds, excessive bending, twisting. But at the same time, you want to avoid bed rest. If you stay in bed for a very long period of time, you can decondition your back, and it can put you at a higher risk for relapsing episodes of back pain. Now, if you do have severe symptoms where it's hard for you to do anything and any activity makes the pain worse, you may want to take bed rest for a couple of days, and then once you feel better, start being active again. If you are overweight, you want to consider losing weight, and if you're smoking, consider stopping. You may be given a combination of medications by your provider, which work together very well to treat pain. One of the first things we'll start out with include anti-inflammatory medications such as ibuprofen, naproxen, meloxicam. You want to take this medication for a short time, maybe 1 to 2 weeks for the acute episode of pain. If you do take it for a very long time, you can have side effects that you need to keep in mind. This includes stomach pain or irritation from an ulcer, kidney damage. It can also put you at higher risk for a heart attack or a stroke. You can also try Tylenol over the counter for pain. You may be given a steroid pack to help reduce inflammation in the back, and this is typically for 6 to 7 days. You may be given muscle relaxers to try for tightness in your back or cramping sensation in your legs. If you have back and leg pain for a long time, maybe 3 to 4 weeks or more, you may be given nerve pain medications such as gabapentin, Lyrica, or Cymbalta. They help reduce the spontaneous nerve firing and the nerve pain. If none of these medications work very well, you may be given opioid medications. In general, opioid medications do not work very well for nerve pain. And there are a lot of side effects with opioid medications to keep in mind, such as constipation, sometimes nausea, vomiting, and also addiction and dependence. So we want to avoid using opioid medications if there are other things that help with pain. You also want to try therapy, with physical therapy being most effective. With a physical therapist, once you're referred, you'll work to learn low impact exercises to strengthen both your back muscles and leg muscles. You'll also learn different types of stretching exercises to relieve pressure around that nerve and pain. They'll also use different modalities such as maybe a TENS unit, ultrasound therapy, or massages to help with pain. You can also try acupuncture and gentle spinal manipulation, which have helped some patients, as well as yoga and behavioral therapy. Some of the other things you can try at home, which are low cost, includes a TENS unit, which has been shown to help about 20% of patients. Sometimes you can ask your doctor for a prescription for a TENS unit, and some insurances do cover it. You can also wear a back brace intermittently throughout the day, especially during activities that worsen your pain, such as a lot of standing, bending, maybe being in a car for a ride. You do want to avoid using it constantly throughout the day because it can weaken the muscles around the spine. You can also try heat or ice therapy. Lastly, if you've tried all these different things and you still have significant back and leg pain or pain that's getting worse, you may want to consider getting an epidural steroid injection by a pain management specialist. Studies have shown that if you get series of epidural steroid injection, typically series of three, it can reduce your need for surgery, and it can help significantly with pain. So what does epidural steroid injection involve? It involves placing steroid medication and a numbing medication close to that irritated nerve. This helps reduce the swelling around the nerve, and it can help with pain. The injection can be done in office or at a surgery center with or without sedation. It's done under X-ray to help us visualize where we need to place the medication. So the image on your left-hand side shows a patient lying on their stomach with their back cleaned, and there's an X-ray machine over the patient and we're getting serial images as we're doing this procedure. The screen shows the X-ray images by the head of the patient. And then the image on your right-hand side shows the green is the steroid medication that's deposited around the irritated nerve. There are certain reasons for which maybe surgery may be indicated. It is considered urgent if you have progressive development of numbness or weakness in your legs, or if you start losing control of your bowel or bladder. It may also be warranted if you've had back and leg pain for more than 6 months that has not improved with conservative treatment. Dr. Vigneswaran will give you more information about the different surgical options we have available for pain from a bulging disc and pinched nerves. If you have any questions, please let us know at the end. Thank you.
Thank you so much.
Great. All right, I'm going to thank you, Hiral, for that. My name's Krish Vigneswaran. I'm a member of the UTHealth Neurosciences faculty and part of the neurosurgery group. One of the neurosurgeons practicing in the Sugar Land Southwest region. And along with Hiral, we are teaming up to help provide a service aimed at addressing this really chronic issue of back pain that has affected a lot of Americans, over the years, and has led to an opioid epidemic, unfortunately, that has led to an overprescription of medications for truly organic causes and things that can be fixed with a lot of the things that Hiral has gone over, and also ultimately some surgical things that I will now address in how we work up patients and determine whether or not they are surgical candidates, and then what surgical options we have for them. So I'll begin by getting my screen shared here. 1 second. Pager's going off. All right, Elise, I'm trying to get my slides up there. Can you help me out there? Saying who can share? Only host. I'm the host. Should be sharing.
Yeah.
Elena, do you have him as a host?
I had him as a co-host, but I can certainly make you a host right now. There you go.
Let's try this one more time.
Continue to put your questions in the chat feature while we're working on that. I know we have some great questions.
All right, there we go. Just got started here. And I'll share my screen too. And that will share. All right. So I think Hiral had gone over some of this already. So, to review real quick, the normal lumbar spine anatomy, we're focusing really on the lower portion of the spine. This is where all the pathology and the pain is coming from. And when we as physicians look at the lower portion of the spine, we're trying to understand, is the pain coming from the bones in the spine, the nerves in the spine, or the actual joints in the spine? And then we have a better idea of how to target that pain, either medically or through interventions or ultimately through surgery. So these are some of the imaging modalities that we, when you come to a neurosurgeon, we start to ask for and have generally acquired prior to visiting or after you've seen us, we will set you up for. On the left here is an X-ray. This is pretty standard. This is going to be the image that you get when you come in to an ER or to your primary care doctor with low back pain. They'll usually get an X-ray to start off. And what they generally look for here are fractures. Do you have a broken bone in your back? And that's usually the only thing you can tell on an X-ray, and that's the best way to tell. Here you have a CT scan, the second one. CT scans, again, are really good at looking for fractures and really looking at bony anatomy. Other than that, it can tell you kind of how the joints look, if there's a lot of arthritis in your lower back. And sometimes it can tell you, if you have a abnormality on how your bones are aligned, or if you have scoliosis or some other type of poor alignment in your spine that may be causing some of your pain. We'll skip the one here on the third and go straight to this one called the MRI. This one I'm sure a lot of folks have had before. This is a study that we all get in order to look at the nerves. What we see here at the very end is the bottom of your spinal cord, which kind of ends here in this little cone. This is the conus, the end of the spinal cord. And then down here, like a horse's tail, are the little filaments or the nerve fibers that all come down and run and down into your quadriceps and your hamstrings, your calf muscles, your toes, and give all the sensation and nerves all the way down. And these are those same nerve roots that end up getting pinched and causing pain and weakness when these discs that we talked about earlier start bulging. So the MRI is the best way for us to see which nerve root is getting pinched by which disc. Now, for folks that have had a pacemaker put in or an implant or something metal in their body and can't go into an MRI or are claustrophobic, then we have to go with this study here, which is a myelogram, which you can see kind of looks like an MRI. It's basically a CT scan where a doctor will put a little needle in and inject dye into the spinal fluid area. So now the fluid lights up white and we can see all those same nerve roots. So a myelogram is just as good as a MRI, but again, it's a little bit more of an invasive procedure as opposed to an MRI, which doesn't have any radiation, doesn't have any needles going in, doesn't require any procedure to be done as opposed to the myelogram. But these are the studies that we use to make diagnoses. So when it comes to the pain, we try to understand where is it coming from? Is it in the nerve root? Is this a radiculopathy? Is the nerve root being pinched? And if that nerve root is being pinched, is it being pinched off at the level of the joint? Or is it being pinched off at the level of a disc that's bulging or broken down? Or is the pain coming from the actual spinal canal? Is there actual tightness of the canal, which we call stenosis and narrowing of the spinal canal that's pinching off that whole clump of nerves as it's coming down? And finally, is there actual pain in the bones? Is there pain that's mechanical in nature because the bones are shifting around in your back? And is that actually the source of the pain and leading to the central back pain that we commonly see? So we have to kind of break down based off of that history that Hiral was talking about in talking to you to understand, is this a pain that's shooting down your leg? Is this a pain that's really central and stuck in your back? Or is this a pain that comes from your back and radiates out to your sides? All of these are really big clues in helping us localize where is the pain, and then narrowing down the studies on the imaging to find out where we can make our best effect. So focusing on the nerve root, is it something that's caused by a nerve root compression? We look at first, is it a disc, a bulging disc that's sticking out and herniating? So again, like Hiral showed, these are some images and illustrations of what we see. What typically is seen is in the lumbar spine, we have these discs, which are like shock absorbers made of this gel. And over time, that gel goes bad, and over repetitive stress and bouncing up and down and jumping up and down, you start to have breakdowns in the annulus, or which are kind of the ring on the outside. And every now and then a little bit of the disc material can squirt out and pinch the nerve. And that's what you see here on the MRI. So that's what we look for on your MRI, is a bulging disc causing a pinched nerve. And this is another cartoon illustration of how that disc can bulge out. It can either bulge out centrally and pinch the nerve at this joint, or pinch the nerve out very far laterally. And all of these can present with pain in a different way. Sometimes you have arthritis out here in the joint section. Each of these bones in your lumbar spine are mobile, and they ride one on top of the other with those discs, those shock absorbers stuck between them, but they're mobile. That's what allows you to do that yoga and bend over and touch your toes. But as you keep doing that over and over again, those joints, just like the joints in your elbows and your knees and your shoulders, become arthritic. And just like those other joints, they have cartilage that sits here in this area called the facet. And as that cartilage wears down, you develop arthritis. And that arthritis leads to bony overgrowth and the common term bone spurs. And those spurs eventually can dig into those same nerve roots, just like a disc can, and cause equivalent amounts of pain. So here's an illustration of how those bone spurs can pinch the nerve just like a disc can pinch a nerve. And here's what we normally see, a nice open area where the nerve root exits between the two adjacent levels of the lumbar spine. But here is what we see when you get stenosis or foraminal stenosis. When this cartilage between these two joints erodes away, what was nice and big opening and a big hole here goes away. And now that nerve is trying to squeeze through this tiny little hole, and it can't. And that's where you get a lot of the pain. What that looks like on an MRI is we're looking for a nice sunny side up egg, a nice white outside, and a nerve root in the center. That means there's a wide open space for that nerve to come out from. But when we have stenosis, it looks like this. No white on the outside, just a black nerve root there in the center getting squished by bone all around it. And that tells us that this is an area of stenosis where the nerve root is not very happy, and it's going to be a site where the pain is coming from. Finally, again, like I alluded to, the joints themselves, as they start to break down and become arthritic, they can actually get overgrown. So here again is another MRI showing you now that the foramen, or that hole where the nerve is coming out, is already stenotic. You can see that there's just a thin rim of white around the nerve root. Over time, that thin rim of white starts to go away, and eventually it becomes pretty much black and goes almost completely away. And that nerve root is just a sliver squished in here, and the joint has overgrown and become really large. And sometimes you get cysts that grow out of the joint capsule that can compress the nerve root, called synovial cysts. And these are all basically compartments of the same process called degenerative disease of the lumbar spine. And these are all things that happen as we age and put more stress and trauma onto our back, but things that we can slow the progress down of as we go through healthy habits such as smoking cessation, weight loss, yoga, physical therapy, exercise, are all things that help mitigate and stop this process from ever happening to begin with. Now, if this process has happened and you have gone through those conservative management options of pain management, PT, injections, and you've gone through everything and you're still in significant pain, or you're in pain and you're now having weakness. Weakness is the key. if you're starting to lose strength in a muscle group that is innervated by that nerve, that's a real big sign that surgery is definitely now become an indication for moving forward. So again, here's another picture of how this arthritis looks. That nerve root's angry and pinched off. Again, it can be either from bony overgrowth or it can be from a bulging disc. In order to address this, what we do is a small procedure called a foraminotomy, which basically means we open up the foramen or the hole that this nerve root is exiting through by doing a decompression. We make a small incision right over the area where that stenosis is, and we drill a very small hole right over where that tightness is, and we basically open up the area where the nerve root is getting pinched. Right over here, we basically drill all this arthritic bone off so the nerve root is free to pass. In the case of there being a disc herniation, once we get down to the level of the disc, we're able to mobilize the actual spinal cord over to one side and reach down underneath and actually pluck out the disc that's herniated out so that it's no longer putting pressure on the nerve. Similarly, you have overgrown facets. These facets, which are those joints, can sometimes get really large and push on the nerve. We can shave those down so that they aren't causing any more pressure. Basically, all in all, the idea is trying to make more room for the nerve root where there used to be less room. And that can be done microscopically through a small incision using these various surgical techniques. As neurosurgeons, we're trained to do this all using a microscope. And I'll briefly show you an illustrative video of how we do that in a moment. Again, the foraminotomy, medial facetectomy procedures, we do this usually through a tubular retractor system, meaning we basically make a small incision and then we put a small tube, and the tube is the channel, the working port that we look through in order to see the anatomy below. And then in doing so, we're able to then look at the nerve and the bone and remove the abnormal tissue. Now I'm going to try and MacGyver some video over. Hold on one second, bear with me. Let's see here. New share screen one. Share. All right, and so this is an example of a microdiscectomy where we basically start off by localizing where the level of the surgery is to be performed. After we've identified it, we make a small incision, and basically after that point, we use a series of little dilators to slowly dilate the area up to the point in time where we can use that same tubular retractor system, like you see here, using an X-ray to get us to the right place. Once the X-ray has been completed, we use a microscope and this tubular retractor to basically get us down to the area that we are interested in. Using a high-speed drill, we drill off that arthritic bone that's overgrown in that area, and we remove it so that we're able to expose the spinal canal and then the spinal cord. Here you see us retracting the spinal cord to the side. This is the spinal cord itself and the nerve root, this shiny glistening thing to the top of the screen. And as you pull it to the side, you'll start to see underneath the actual disc material. So this right here is the fibrous capsule of the disc. Once it's identified, the most gratifying thing to do is actually cut into the disc itself. And so once it's cut into, you get this release. Oh, that feels so good. Pull out that herniated disc material that's been pushing there, and you get these big balls of fragment that have been sitting there pushing on the nerve root for a long time. And that's what's left behind, basically a little hole where the old disc fragment was sitting before. And that's all pretty much done through that small micro disc incision. Again, to kind of zoom back out, we put a little bit of steroid there afterwards, but this is that same tubular retractor system that's used. And then at the end of the procedure, we have a small incision that's about, a couple of maybe a couple of centimeters, about 3 or 4 centimeters along the mid back. So again, that's an example of how we go about doing that procedure. So we are now, let me make sure I'm on the right screen again. Yeah, okay, screen 2, share. So going back into the where the pain's coming from, I know we're running short on time here. The pain can also be coming centrally. Here you can see it now. We're no longer talking about nerve roots. We're talking about actual pinching of the actual cord itself. As you can see here, there's central stenosis. We're looking now at those nerve roots as they come down, that horse's tail, each getting pinched off at separate levels. Usually when you have this type of pain, you have neurogenic claudication, you'll have more weakness. You'll actually feel like your legs give out from under you. As you walk over a period of time, your legs feel tired. The pain gets better when you're actually bending forward. When you're shopping in the grocery store, you find that when you lean on the shopping cart and push it around, your pain is actually better. When you stand up and stretch your back, it actually hurts worse. And that's because you're straightening your back out and pinching these nerve roots off even more. And but the key is really your legs fatigue out, because all these nerve roots are being pinched sequentially all the way down your spine, and you end up having weakness because now your muscles aren't getting those signals from your brain, and you end up tiring out before you're able to walk around for a long period of time. For this type of problem, we usually do a lumbar laminectomy, which is we remove that overgrown bone at multiple levels and remove it in segments, like a little lobster tail, and that decompresses the spine. Sometimes, depending on the degree of mobility and the bony anatomy, we'll discuss whether or not a fusion is required. And if a fusion is required, we have to place these small little screws on the side with a little bit of rod in order to provide more stability after the surgery. And finally, we talk about mechanical back pain. In some cases, after a long period of time, if the disc is broken down, we get situations like this where the bones have shifted forward, and we get special x-rays where we have you bend forward and extend back. These are called flexion extension x-rays. These are mobile x-rays. And when we do that, we actually see that when you're bending forward, your whole spine kind of shifts forward a couple of millimeters. And when you stand up, the whole spine shifts back. And when that's happening, every single time that happens in your whole life, that causes pain in your back, that causes bone-on-bone erosion, and that's mechanical back pain. That's called spondylolisthesis, and that's displayed here in the x-rays, or here on this MRI. This is an example of how the spine kind of shifts forward. When this degree of mobility is there, eventually this also leads to nerve roots getting pinched, to that same type of stenosis and the weakness we talked about. And this is also addressed in similar fashion, which is laminectomies, foraminotomies. And in this case, definitely you would need to have a fusion. As you see here by the illustrations and the real-time examples, what we do is we decompress the spinal cord, but we also place the screws and rods in to restore normal alignment to the spine in order to reduce the amount of mechanical back pain and the abnormality in the spinal alignment that's ultimately resulting in the pain to begin with. So really, at the end of the day, it comes down to identifying where's the pain coming from, what type of pain is it, and then making sure that we've chosen the correct surgical procedure for that type of pain, especially if it's pain that correlates with a true neurological deficit, which would be a weakness in a muscle group or a group of leg muscles and so forth. Again, so these are our surgical sites at Memorial Hermann Sugar Land and Memorial Hermann Southwest. And if there is any type of emergency situation where you find that you're having some of those red flag things that Hiral talked about, bowel or bladder incontinence, immediately, not able to move your leg for any sort of reason, these fevers, any of these issues, definitely come straight to the emergency room. And we are available on call 24/7 at either of these hospitals with our UTHealth Neurosciences group. At Southwest, we have a state-of-the-art neuro ICU where we do larger, more complex cases as displayed on the right. And we're having an installation of a neuro integrated intraoperative suite where we have real-time navigation and 3D robotic assisted surgery that we're in the process of integrating into the already established endovascular suite that we have there, that we do a lot of brain tumors and aneurysms and such. So we're going to be doing some complex spine surgery. At Sugar Land, we do a lot of what you saw, the example of the microdiscectomy. This is our example of our tubular retractor system from one of the companies that we have, which is a very great system that allows us to get quick access down to the level of the pathology through minimally invasive procedures, and try to have you in and out of the hospital within a day, either the same day of surgery, or at least the next day. If it's going to be an afternoon surgery, I like to have you stay overnight just to make sure the anesthesia has kind of gotten out of your system. Otherwise, if it's going to be the morning of, then we usually are good with you going home in the afternoon, as long as you have someone else to drive you home. Both are sites that I operate at, and that we're available to you at, and also for very, very large cases, Texas Medical Center, I also operate there, and or Memorial City. So with that, I will conclude. I think we have time for questions here, and these are our referral sources.
Hi, we've got some great questions from our participants. I'm gonna go ahead and dive right in. Number one, is sciatica present at birth, or can it happen later in life?
Hiral, do you want to take that real quick? Sorry, I have
Yeah,
on call. Sorry.
I'm trying to show my video or my face. Just a second. Can you hear me?
Yes.
Yes. Okay. So in terms of sciatica at birth, there are some genetic component to spine changes, such as your spinal canal can be tight to begin with due to certain genes, which can put you at risk later down the road for sciatica to develop sooner than someone who had maybe normal spine to begin with. But generally, in your I guess youth, you may not have those symptoms, but you may have some spine changes that started at birth, and then you may see sciatica maybe in your 20s, 30s, rather than 40s or 50s, if that makes sense.
Okay. Does physical exercise help relieve sciatica?
Yes, I think it does. Physical exercises, you're learning to strengthen muscles around the spine, especially core muscles, the gluteal muscles, lower extremity muscles. You're also improving your posture, which in the long run can help with pain.
Okay. Which is the appropriate specialist for a bulging disc in my lower back? What exercises do I need to avoid, and what is the best kind of chair to use?
You can start out with your primary care doctor for any back pain symptoms, and then your primary care doctor can refer you to pain management and or neurosurgery, depending on if you have only pain or if you also have numbness or weakness. Something that's amazing about our group is we have neurosurgeons, neurologists, and pain management specialists under one roof. So if you see one of the specialists, depending on our evaluation, you will be referred to one or the other, and we'll treat all different types of pain. And then if you need surgery, then we can guide you to a surgeon sooner than if you were to see someone on the outside.
Okay. For persons over 70, is it beneficial to do chair yoga for seniors to strengthen the muscles around the spines, since it entails a lot of stretching?
I think it is. I think it is beneficial to start with chair yoga. But if you are able to do other types of stretches, which involve standing or bending, etc., then you can also incorporate those as well. But chair yoga is, I think, something good to start with.
Just want to say that the Y has begun to add, and we are including chair yoga in our exercise classes. That's new for us.
Okay.
Great. What exercises are beneficial if one has had spinal stenosis surgery with fusion?
Krish, do you want to take that?
Yeah, I think after spinal stenosis surgery, and especially if you've had fusion, the most beneficial are going to be all your stretching exercises. I think the mobility and stretching are the factors that are commonly overlooked. I think people go straight back into trying to strengthen their lumbar and lower back segments after that kind of surgery. And while it's important to build your low back strength up, I think the stretching is actually a bigger factor because that will help in the longer run. And usually that's less taxing on your body as well. So easing back into stretches is a key part. I would definitely consult with your surgeon prior to initiating that, just to make sure that we usually have some guidance into when it's appropriate to start your bending, lifting, twisting based on what type of fusion you've had. And then at that point, you can start to do not only passive stretching, but also active stretching, where you can add a little bit of weight into your stretches to get an extended range of motion. Once you've kind of moved through the stretching, then you can go back into doing a little bit of weight. But I do actually recommend doing more back extensions. I think the back extensions are an exercise that's commonly overlooked. I think the back is a very neglected muscle group. I think for a lot of folks, we focus a lot on the glamour muscles, our arms and our quads, and we spend a lot of time doing those types of things. But back extensions, doing body weight exercises, really no weights needed. But those types of things are very good exercises to help strengthen the core and strengthen the back.
Okay. For what conditions is spinal manipulation most effective?
I guess it depends on what context of manipulation you mean. I generally have never pushed any of my patients towards any type of chiropractic manipulation. I specifically don't have any literature or academic leaning towards it myself. It may work to different individuals, but I have never found any peer-reviewed literature that has been a resource to me to make good recommendations based off of that. Unfortunately, I have seen complications of it more so, specifically in the neck and in the lumbar spine as well, from pre-operative and post-operative manipulations that have been done without consultation from a physician, and people that have some of the things that we've talked about, bulging discs, or those, if you can imagine having that kind of slipped forward type of situation. So you definitely don't want to go into that type of thing blind. That being said, I think medical massage therapy, and there are very specific masseuses in the Houston area that are licensed medical massage therapists, and they are medical massage therapists, not your spas or massage envies or things, but actual medical massages. I think they're very useful in helping release a lot of muscle tension and pain that can develop in your lower back. And these are usually sequelae of actual central problems, meaning that if you have an irritated nerve root, or if you have a back problem, a mechanical back problem in your spine, the muscles kind of step up to the plate to take over, and they can go into spasm and tighten up on you. And you need a conservative therapy, alternating hot and cold packs, and simply massaging it out, trigger point, getting a tennis ball and having someone roll that on your back. Those are things that will actually help loosen up the muscle and help a lot in pain control, more so than anything else.
Okay. How often can you get steroid injections?
Of one particular kind, you can get 3 steroid injections in 1 year. If you change the approach, you can get that type of an injection the additional times in 1 year.
Okay.
On average, a steroid injection can last 3 to 6 months.
Okay, thanks. If you have chronic back pain, should you initially see a pain management specialist or a neurosurgeon?
I think you can start out with either pain management specialist can start with conservative treatment for you, give you medications as well as try injections. If we get to a point where you start having some of those red flag symptoms such as numbness, weakness, or if you're not improving with conservative treatment, we will refer you to a surgeon for an evaluation.
Thank you. When the pain is in the right side of lumbar area, is it muscle or spine pain?
It could be either. It could be a muscle strain, sprain, or a spasm, or it can be a referred pain coming from some kind of an etiology related to the spine. You can start out by putting heat or ice on it, massaging the area, over-the-counter medications. If it doesn't get better, see a healthcare provider, maybe a primary care doctor, and you may get some imaging done too to see if it's related to any of the, I guess, internal organs, because sometimes you can have referred pain that comes from the front, such as maybe if it is on the right side, it could be related to the liver or gallbladder that you may want to get checked out with possibly an ultrasound, an abdominal ultrasound. You could also get an ultrasound of your kidneys if it is a referred pain coming from some kind of kidney etiology. Yeah.
Okay. Once one has had a laminectomy with fusion, will this last for the rest of your natural life?
Yes, so the laminectomy is, the actual decompression and the removal of that bone over the top of the spine. So you've unroofed the spinal canal, and that bone though can grow back, and you can get over time potentially restenosis. We have seen that in some patients, and that is an issue sometimes. Very rarely, but it can happen. I can't say I've never seen that before. The fusion itself will, again, should last for your lifetime, but there are factors that can make a fusion not last. Those screws go into your bone, but it's only as good as the quality of your bone. So imagine your bone, it should be like a block of cement, but if your bone is like drywall because you smoke or you've got real bad osteoporosis or you've got something else, those screws will start to loosen and they can back out, and then you've got a problem there. So we do a lot of things when we counsel you on surgery and fusion about risk factors for bone healing and how we want to get around making sure you heal well. And we add some things during the time of surgery to make sure the fusion lasts long. And then another key factor is once the surgery is completed, we follow you with x-rays over a 3-month, 6-month, and 1-year interval to make sure that that fusion is taking and that the bone is healing. Because at the end of the day, the screws and the rods are purely a scaffold, just like a scaffold to build a building. It's just, they're like the beams inside of a building. The cement is the bone that's poured over the building to actually make it look like a building. So once we put those screws and rods there, we're waiting for bone to grow over all of that for the actual fusion to happen. And so that's what we want to see on the x-rays over time.
Okay. Would you recommend an MRI just to see condition of the spinal cord area as it is before problems arise?
No, I wouldn't go searching for things. Yeah, I think, like we've talked about, some of the signs and symptoms of things to be concerned about that should prompt you to go and see your doctor would be if you're having new weakness, numbness, bowel or bladder issues, or significant pain that's not getting better with some of the remedies we've talked about, and then have a physician evaluate you and determine if an MRI is worth it. But definitely wouldn't just go get one.
Okay. Can a pinched nerve that caused numbness in the hip have any effect in the brain, such as dizziness?
It should not cause dizziness from a localized pinched nerve in the lumbar area. If you are having dizziness that is, for example, positional, it could be related to an issue with blood pressure, for example. It could also be related to an issue with fluid in your ear. So you do want to get it evaluated with your primary care provider.
Okay,
It generally is not related to a pinched nerve in the back.
okay. Can arthritic back pain be caused by diet?
I think there is some truth to that because there are certain foods that are shown to be pro-inflammatory, such as processed foods or foods high in sugar. Certain types of meats, such as red meats, can increase overall level of inflammation in your body, and that may contribute to pain. Not necessarily sure it would cause like progression of arthritis, but there is some weak association between the two.
Okay. How often should one take oral steroids?
It's generally not recommended to take steroids too often because steroids in the long run can have a lot of side effects, such as it can affect your blood sugar, put you at risk for diabetes. It can affect your blood pressure. It can also affect your bone mass. So if you take steroids too often, it puts you at risk for brittle bones later down the road. It can also affect your immune system and hormone levels in your body. So I wouldn't take it too often. Krish, do you have an answer to that, or in terms of how often you should take oral steroids?
Yeah, usually the steroids that are prescribed in the context of the pinched nerve and back pain are prescribed via, well, you'll get a dose pack or a Medrol dose pack, and these have a very fixed amount of time, usually no more than 5 to 10 days. And it's in a tapered fashion, meaning it'll say take X amount for X amount of days, then take, X amount for this many days and this amount for this many days. And it kind of gets you from a higher dose to a lower dose over a period of time. And that's how those are prescribed in flare-ups of nerve pain. So yeah, no one should be taking chronic steroids for pain, specifically this type of pain that we're talking about, pinched nerve, back pain type of pain.
Okay, I think we have the time for the last two questions, and then we'll have to wrap up understanding the doctor's time today.
Okay. How is treatment different between spinal orthopedic and neurosurgery? When screws and a rod are added, how does it affect bending?
When it comes to the spine, we both, neurosurgeons and orthopedic surgeons, both operate on the spine. Traditionally, our trainings are different. We as neurosurgeons go through 7 years of training. Orthopedic go through 4 to 5, and orthopedic doctors do every bone in the body, arms to legs to hips to everything. But we in neurosurgery focus exclusively on the brain and the spine, and then we are also very much focused on the nerves. As you probably heard from my talk, I really focus my conversation really on what is the MRI and myelogram and what nerve is being impinged, what muscle group, and trying to localize the actual pain and try to decompress a nerve issue. I think orthopedic surgeons are really good, and I would completely defer to them for deformities like scoliosis, things there where there's a lot of, we have a lot of colleagues in orthopedics that we love to work with that are like engineers, really. They deal a lot with like angles and deformity and trying to correct the angle of the spine and things like that. So yeah, generally when I've been counseling folks, that's how I've kind of divided the two up. But in terms of the screws and rods and bending, it depends on the number of levels that we're fusing. If we're doing just a single level, like L3 to L4, you'll barely notice any difference in your degree of mobility. But we generally say about 10 degrees of motion are lost per level that are fused. So if you're fusing L1 to pelvis, yes, then you're definitely going to be losing a great deal of your mobility. But those will be things that physicians will go over with you.
Okay, thank you. So this is our last question since we're out of time, but my golf swing slightly stresses my lower back with slight pain. How concerned should I be? I
guess as long as the pain isn't radiating into your legs or causing any new weakness. It may just be a mechanics thing. Maybe, talking to your instructor and making sure the way that the swing is happening is right, and we're not overdoing it there. But at the point in time that you're finding that the exertion of the swing is persistent and the pain lasts beyond the driving range, and it's all through the day, and no position you're in can make it comfortable, and it's always there, and it's constant pain, and it starts to maybe radiate to another area, that's when you should start getting concerned. But if it's something that's happening only when you're out there on the range and it goes away as soon as you stop that motion, it's probably more of a mechanics of the swing, which we see commonly. I mean, anything from tennis elbow to pitchers to any athlete that may be doing the motion the incorrect way can usually stress their body in a manner that needs to just reform their mechanics on the sport itself.
Great, thank you. I guess I won't be winning the trophy. That's the only thing, but that's okay. Thank you both, Dr. Patel and Dr. Vigneswaran, for being here today. Really appreciate it. Thank you all for attending. Thank you to UTHealth Neuroscience. Stay safe, have a great day, and I'll send everybody the recording. Bye-bye now.
Bye.